Welcome to the Radiology Vault, an open repository for radiology educational content designed for learners and medical professionals. Presented by the Michigan Medicine Department of Radiology.
Hi, my name is Molly Roseland. I'm a nuclear medicine radiologist at University of Michigan. Today I'm going to be discussing PET imaging in large vessel vasculitis. I have no disclosures. Main objectives are to review the diagnostic criteria for active vasculitis on PET, to review the common large vessel vasculitis subtypes, which are giant cell and Takayasu, and their imaging appearances, and then to review a few vasculitis mimics and pitfalls. So any radiologist that routinely interprets FDG-PET for malignancy knows that there's often uptake in various infectious and inflammatory conditions. And so large vessel vasculitis is one such condition that we can image by PET. There are some classic patterns of FDG uptake that are worth recognizing, and if we do, then PET becomes a useful adjunct to traditional diagnostic vascular imaging like CTA, MRA, or vascular ultrasound. And so in this case, FDG-PET is a useful problem-solving tool for rheumatologists in patients with suspected vasculitis. So what is large vessel vasculitis pathologically? It consists of granulomatous inflammation of the aorta and major branches. So there are actually two subtypes that have very different imaging and demographic features. Those are giant cell arteritis and Takayasu arteritis. Symptoms can be nonspecific, sort of systemic symptoms, sometimes neurologic or vascular symptoms. Labs might just show elevated inflammatory markers, but often the diagnosis is not cinched until some imaging is obtained. The major rheumatology societies do endorse FDG-PET for non-invasive diagnosis and also for prognostication. So temporal and axillary ultrasound plays a big role in diagnosis of giant cell arteritis. CTA and MRA plays a role in either type of large vessel vasculitis, and so PET is used alongside all of these typical anatomic modalities. So what kind of diagnostic criteria do we have in order to determine if a PET scan is positive for active inflammation or active vasculitis? Well, you want to look for diffuse uptake in the walls of the aorta or other large arterial branches, and this should be in the absence of significant calcified atherosclerotic plaque. Ideally, you have a comparison recent CT or MR angiogram to compare and look for the sites of potential disease, and ideally PET should be obtained early in the disease course before steroids are initiated or shortly after to improve sensitivity. A very simple visual grading scale, really similar to the Deauville score for lymphoma, is endorsed by the Nuclear Medicine Societies for grading. And simply, that consists of if there is increased uptake in the wall of a vessel that is greater than liver background, then you have a positive scan. Always, when assessing a scan for the presence of vasculitis, don't just look at the aorta, but make sure you pay attention to subclavian, axillary, carotid, iliac, and femoral arteries as well. Again, to not miss the diagnosis if it doesn't involve the aorta, or to get a complete assessment of distribution of disease. So this is an example of that visual grading scale, where a clear positive scan on screen right, where there's circumferentially increased uptake in the walls of the aorta, much greater than liver background or just slightly above liver background. Both cases, this case is slightly less obvious, but both are positive. This equivocal case, I'm starting to see an outline of the vessel wall of the aorta, but it's not greater than liver background, so it's equivocal. These negative cases, I'm seeing the aorta, but this low-level uptake is not really in the wall, it's just the lumen, and that's related to vascular blood pool, so these cases are negative. So what about giant cell arteritis in particular? Well, think about this diagnosis on a PET scan if you have an elderly patient to begin with, and they should have homogeneous circumferential long segment FDG uptake in large arteries. And that's useful for prognostication because uptake positive PET in these patients indicates a higher risk of degenerating into aneurysm. There are two main phenotypes or areas of involvement, and so PET mainly plays a role in diagnosing the large vessel subtype. And when there is involvement of vessels that we can see, it's most often the aorta, the arch and arch vessels, and the subclavian and axillary arteries. So that's this distribution we see here, where very intense uptake in the thoracic aorta, arch, descending thoracic aorta, as well as the subclavian arteries here. And what do we see on CT? There's concurrent vessel wall thickening, perivascular soft tissue, and fat stranding, right where there's uptake circumferentially on PET. There is a cranial subtype of giant cell arteritis, and that involves arteries in the scalp, for example, the superficial temporal artery. PET doesn't really play a role in this diagnosis. It's typically performed with ultrasound or biopsy. Large vessel giant cell arteritis can manifest in sort of a little bit different distribution, so this is slightly different, but still similarly involves aorta and subclavians. So here we have the diffuse bilateral subclavian involvement with increased uptake here relative to the liver, associated with some concurrent vessel wall thickening on CTA that might be a little bit subtle, and so PET really illuminates this area of involvement very, very well. There's also increased uptake here in the abdominal aorta, sparing the thoracic aorta and bilateral iliac arteries. So here we can see there's circumferentially increased uptake in the abdominal aorta, and then associated with some vessel wall, perivascular soft tissue, and thickening on CT. What about cranial arterial involvement in GCA? So PET, we really are not typically expecting to see anything in these arteries because PET has a poor resolution and sensitivity. However, if you have profuse inflammation or a high-quality new PET scan, seeing uptake in these scalp arteries, for example, anterior to the ear here, has very high specificity for the diagnosis. So always look at the scalp arteries, but don't expect to see any uptake. Polymyalgia rheumatica is a condition that is not a vasculitis, but often accompanies giant cell arteritis and can also cause nonspecific systemic symptoms. So it's a useful diagnosis to be able to make by PET. It consists of enthesitis and bursitis, and so you most often would see uptake in the interspinous bursae between the spinous processes, but also there's often uptake at the tendinous insertions of large muscles around the pelvis, and then periarticular uptake at large joints like the shoulders and hips. Even though it's called polymyalgia rheumatica, there is no muscular uptake because it's not a myositis. So just note that, even though the name is a little confusing. So this is an example of polymyalgia rheumatica on PET in a patient that did not have a concurrent vasculitis. You see there's periarticular increased uptake in the shoulders, and then increased uptake here at the tendinous insertions of numerous pelvic muscles, and then uptake in the interspinous ligaments. So very classic distribution. Takayasu arteritis. This is in contrast to giant cell arteritis. Think about this if you have a young woman that has circumferential segmental large artery FDG uptake. And so in these cases, whereas PET and GCA indicated an increased risk of aneurysm, in this case it indicates an increased risk of stenosis or occlusions. And those can be very morbid for these patients and really emphasizes the urgency of immunosuppression. So compared to giant cell arteritis, the imaging morphology is a little different. It's often multifocal, discontiguous, and stenotic, and it's more likely to involve different arteries. So whereas GCA involves subclavian and axillaries, Takayasu often involves renal, mesenteric, and carotid arteries. So this is an example case of a patient with very intense perivascular soft tissue thickening and also luminal narrowing of the right common carotid artery with intensely increased uptake here on PET, long segment. You can see on PET, it also illuminates that there is other sites of discontiguous disease involvement of the right axillary artery and bilateral superficial femoral arteries. And really, PET allows you to see these sites of disease that might not be imaged with a typical CTA. This is another example of a patient that had diffusely increased uptake in the aortic walls, so an aortitis, and also some involvement of arch arteries with, again, that classic perivascular soft tissue thickening and luminal narrowing here of the left carotid. So what about monitoring treatment in large vessel vasculitis? Typically, routine follow-up PET scans are not obtained in patients because some vascular uptake can persist over time, although in general, with successful treatment, vessel wall uptake does tend to decrease over time. But typically, these should not only be obtained if there's concern for worsening symptoms. What about some major pitfalls? Biggest false positives are inflammatory atherosclerosis, and so always comparing with a concurrent CTA to look for any non-calcified plaque and making sure that your uptake is not localized around calcifications. But always this should be in your differential if you're looking at an elderly patient. Vascular blood pool can be challenging, and so always compare uptake in the vessel wall to large veins. And then infectious vasculitis, typically you would need a typical clinical history. False negatives are typically for patients that have been on pre-existing immunosuppression, and so think about that. If the CTA shows profuse involvement of disease, for example, here in these arch vessels that are very narrowed and thickened, but there's no concurrent uptake on PET. Mild inflammation you might not be able to detect by PET, and any non-large vessel vasculitis. So, for example, polyarteritis nodosa, that's just not something that we have the resolution for on PET. So always correlate with a clinical history and any imaging to make sure you're not missing something. A few other mimics worth recognizing are other autoimmune diseases can manifest with vessel wall inflammation, so make sure you're aware of the other conditions they have. IgG4 disease or other systemic inflammatory conditions can result in periortitis or aortitis. Rare infections and neoplasms can also manifest with vessel wall involvement. And so think about these if you have atypical or more focal uptake in a single vessel or a sort of strange distribution. So always, rope in your rheumatology or ID colleagues in these cases. You might need tissue. So in conclusion, FDG-PET is useful to diagnose large vessel vasculitis. You look for circumferential long segment aortic and branch vessel FDG uptake. You should not have associated atherosclerotic calcifications. Uptake should be greater than the liver and the blood pool. You should have a typical patient population, typically an elderly patient or a younger woman. Always look for non-calcified atherosclerosis on any prior CTA you might have, and always look for concurrent polymyalgia rheumatica if you think you might have GCA. That's it. These are my references. Thank you.